A very good afternoon and welcome to the session on the topic Abnormal Uterine Bleeding. We are glad to have Dr. Sujata Sharma among us today to help us understand the topic. The doctor will help us understand more in details within the session. So be attentive and take the session very seriously. If you have any doubts, any queries, just post that on the box and ma'am will take the questions by the end of the session. So stay tuned till the last and ma'am, now you have the stage.
Okay. So, a very good afternoon to all of you. Namaste. I'm Dr. Sujata Sharma and I am Senior Consultant at Apollo Cradle Hospital, Amritsar. So, today I'll be discussing a very common problem which is faced by women across all age groups, right from adolescence to perimenopausal age group, that is abnormal uterine bleeding. Abnormal means something which is not your normal routine or which is not normal as per the norms described by the various authors or various societies. And, and since this is a very common condition, the prevalence has a very wide spectrum. 3 to 30% is the overall prevalence of the condition, and this prevalence varies with the age group, with the ethnicity, the country of origin. However, it is mostly seen at the extremes of age group, that is in adolescence. Immediately after menarche. Menarche is the time when your periods start. We call it as menarche, or near the perimenopausal age group in your late 40s. So this kind of abnormal uterine bleeding is more common in these two extreme age groups, although it's not that it's not possible in between the age groups. It's there, and there can be several reasons for it. So first of all, let us know what is normal and what should be labeled as abnormal when it is not as per the definitions. So normal, if we talk about the frequency of the menstrual cycles, the menstrual cycles should vary between 24 to 38 days. I mean, the cycle should end, the total duration of the cycle should not be less than 24 days, or it should not be 38 days. If it happens between 24 to 38 days, we take that as normal, right? If it happens before 24 days every time, we call it frequent menstruation. And if it happens at intervals which is later than 38 days, again we call it infrequent menstruation. Then how much should be the duration of normal menstruation? Menstruation means the normal period, normal number of days for which the bleeding is acceptable. So less than 8 days, if you bleed for less than 8 days, that is now taken as normal. But if the bleeding once starts and continues for beyond 8 days, then that is not normal and is taken as abnormal uterine bleeding. How much is the regularity of your cycles? Regularity means, do they occur every time after 28 days or 26 days, whatever is fixed as per your physiology, or there is a cycle variation. Cycle variation means sometimes they happen after 26 days, or sometimes they happen after 35 days. So what should be the normal duration or the normal regularity of the cycles? 7 to 8 days the change in the regularity, okay, that is acceptable. If the periods sometimes they happen 7 days earlier, another time they happen 7 days later, or 3 days earlier, 3 days later from your previous date, so anything less than 7 days is within normal limits. And the menstrual duration, which is more than 8 days, more than 10 days, 8 to 10 days, is then taken as irregular periods. Now, how much should be the flow volume? Flow volume, this is the patient's perception, whether it is normal, it is light, or it is heavy. If you are having periods which are normal as per your normal routine, it's okay. But if you think they were coming more earlier, but now the amount of bleeding has decreased, you are having lighter bleeding, then we don't take that as normal. Or if it has increased, the amount has increased, from volume has increased over the time, then that is taken as abnormal. So what is a normal flow volume? So for any menstrual cycle, a loss of 35 milliliter of blood during menstruation, we take that as normal. But if it is more than 80 ml per day, that is taken as a heavy menstrual bleeding. Heavy menstrual bleeding more than 80. Now, how to calculate that 80 ml? So, the pictorial charts are available online. How much a sanitary napkin can absorb and how many sanitary napkins do you use in a day. Based on that, you can calculate the total amount of blood loss per day or per cycle. Do you have any intermenstrual bleeding? If it is none, then that is absolutely normal. But if it is there, then whether it's random. Random means it can occur any point of time during your entire menstrual cycle, or it is fixed. Fixed means you have regularly, you have spotting or some kind of bleeding in the first part of the cycle, in the first say 8 to 9 days of the cycle, or you have a mid cycle bleeding around the time of ovulation, or you every time have bleeding during the later half of the periods. So if it is a cyclical intermenstrual bleeding, any kind of intermenstrual bleeding, whether it is cyclical or random, is taken as abnormal. So now we know that abnormal uterine bleeding is when your cycles are shorter than 24 days or they are longer than 38 days. You bleed more than 8 days, and the longest to shortest duration is between 7 to 8 days, or it is more than that, 8 to 10 days. Amount of bleeding is heavy or very light, and if you have intermenstrual bleeding of any kind, that is what is abnormal uterine bleeding. So what are the causes which can cause abnormal uterine bleeding? There are certain situations which are structural conditions or structural pathologies, and then there are non-structural pathologies which can cause abnormal uterine bleeding. Structural pathologies, I mean the pathologies which we can palpate. We can examine the patient and find out that there is something wrong with the uterus, or there is some problem with the uterus, which can be imaged. Image means it can be detected on ultrasound, CT scan, or MRI. Or if some biopsy has been taken, then that can be diagnosed histopathologically. So these are structural abnormalities. And structural abnormalities there can be polyps. Now polyps, uterine polyps, that means the polyps in the endometrium. Polyps can be endometrial polyps, or they can be fibroid polyps. Leiomyoma we call them in medical terms. So fibroid polyps, or these can be simple endometrial polyps. Fibroid polyps are a separate category. They will come under the fibroids as a structural cause. But endometrial polyps, if they are there inside the uterus, endometrium is the innermost lining of the uterine cavity. So a uterus is there. The innermost lining of that uterine cavity, we call that endometrium. And if it has overgrowths, right, we call them as polyps. So if polyps are present, they will cause heavy menstrual bleeding. They can also cause intermenstrual bleeding, and that is not a normal bleeding. Another reason can be the presence of adenomyosis. Adenomyosis is one condition. So this is palm coin classification, or the reasons for abnormal uterine bleeding. Adenomyosis means there is a focal or a diffuse thickening of the uterine wall. The uterus increases in size, can increase up to equivalent to 3 months pregnancy size. That is the maximum which it can grow along with adenomyosis. So any presence of adenomyosis, whether this is a focal thickening, just one patch of adenomyosis in one wall of the uterus, or it is diffusely scattered across the walls of the uterus, this can be adenomyosis. And as it grows the size of the uterus, and because this is a hormone dependent condition, Of course, this will also lead to, it might also lead to thickening of the endometrial lining, and when the uterus increases in size, when the endometrium increases in thickening, again this will cause abnormal uterine bleeding. Another cause can be presence of structural. Now this is a structural cause. The third structural cause can be the presence of fibroids or leiomyomas. Fibroids, I think everyone knows. I also gave a lecture last time on fibroids. So presence of fibroids inside the uterine cavity or inside the wall of the uterus, they again will lead to abnormal kind of a uterine bleeding. Now bleeding of adenomyosis and bleeding of fibroids is a regular cyclical bleeding. Okay, you will have your periods at the time when you usually have. There will not be much difference in the cycle variability. The periods, you will get periods at your usual time, but the amount of bleeding will be more, and the days of bleeding, they will increase. So that is very typical of adenomyosis and leiomyoma, and they need to be differentiated and can be easily differentiated if you go in for an imaging, like you can go in for an ultrasound or an MRI. So it's very easy to distinguish between the two. So fibroids, as I said last time, the fibroids which are closer to the uterine cavity or within the wall of the uterine cavity, they are the ones which will cause excessive uterine bleeding staying for a longer time. But the fibroids which are more towards the outer wall of the uterine cavity, now this outer wall is towards the rest of the abdomen, so they do not usually cause much bleeding. But if they are too big in size, they can cause other pressure symptoms and some other pathologies for which some kind of treatment will be needed. Then another structural cause which can be easily identified, we can see it on ultrasound, we can see it on MRI, CT scan, or even on biopsy, is malignancy. So these are structural conditions which can lead to abnormal uterine bleeding. So malignancy of the uterus, the uterine cavity, the leiomyosarcomas or adenocarcinomas, in any malignancy of the uterus, uterine wall, that can also be a cause of abnormal uterine bleeding. And if malignancy is there, the pattern is more irregular. Okay, you will have the more than the anybody who is having intermittent bleeding, intermenstrual bleeding, which is erratic. It can happen any time of the cycle. It's not fixed. It will happen in the first part of the cycle or the middle of the cycle or the last part of the cycle. But intermittent irregular bleeding goes more in favor of malignancy. Not that every time you will have malignancy only. It can be a pre-malignant condition. It can be some endometrial pathology also. It can also happen because of the presence of polyps, or it can also happen because of the presence of fibroid polyps if they are somehow eroded and infected. But malignancy, depending upon the age group, we can see what is the most likely cause of intermenstrual bleeding in such women. Then there are certain non-structural conditions which can lead to abnormal uterine bleeding, and these are if you have coagulopathy. Anybody having coagulopathy means a problem with the coagulation of the blood. Coagulation, I mean the clot formation of the blood. It doesn't coagulate easily. So if anybody having a coagulopathy, in that case abnormal bleeding can happen. It can happen, I mean the amount of bleeding can be more, and it can bleed for more number of days also. Then it can also be there because of some ovulatory disturbances. Ovulatory disturbances means whether egg is forming or not. So in general, if your cycles are regular, coming at regular intervals, yeah, and you are having your menstruation for a fixed period and days, fixed number of days, very regular, very normal cycles. Normal regular cycles are indicative of ovulatory cycles. That indirectly indicates that ovulation is happening and your eggs are forming. In certain conditions like PCOS, which is very common these days, you see young girls, unmarried girls, right, up to perimenopausal age group, all spectrum of age groups, they can be suffering from PCOS. So in PCOS, ovulatory dysfunction is there. Ovulation problems can be there. Not that everyone will have it, but majority of the women will have ovulatory disturbance. And if ovulation is not happening, periods will be delayed. More, that is one of the hallmark of ovulatory dysfunction. So if you have periods which are happening at interval of more than 38 days, and they are the volume is less, quite less, and sometimes they happen after 2 months or 3 months. So infrequent menstruation, less in amount, goes more in favor of any ovulation problem resulting in abnormal. So anything excess, anything less than normal, both are abnormal uterine bleeding. Then endometrial pathologies. Now, endometrium, as I said, is the inner lining of the uterus, and this inner lining of the uterus is the one which is responsive to our hormones, the female hormones, estrogens and progesterones. So, cyclically, after every menstruation, a new layer of endometrium forms, and at the end of menstruation, this layer of endometrium, which was formed throughout these 28 days, it just sheds off in the blood of menstruation. And then again, right from the day it stops, or in fact right from the day your menstruation starts, a new layer begins to form. So this is a uniform process which keeps on happening throughout the life of a woman as long as she is menstruating, the endometrium forming and endometrium shedding off. Now anything which is abnormal, if your hormone levels are abnormal, estrogen is dominant, progesterone is less, or estrogen is less, and androgens are in excess, any hormonal problem in a woman, then that will affect the endometrium as well. So endometrial pathology, which is basically based on the hormones, is again a cause of and this thing abnormal bleeding. Now in conditions which are estrogen dependent, like fibroids, like polyps, so like PCOS, in all these conditions the endometrium becomes more thick. It keeps on becoming more and more thick. So more of endometrium which is to shed, more will be the bleeding. So if the hormones are less, endometrium will be thin, and a thin endometrium, that means the amount of bleeding will be less. So local endometrial pathologies can be the reason for your abnormal bleeding. Then iatrogenic. Iatrogenic means you are being given some medication for some condition of yours which is mandatory to be given, but that condition also affects your menstruation. Maybe you are taking some hormone treatment for some reason, for some endometrial pathology, or for the correction of some other kind of this pattern, abnormal uterine bleeding pattern. And if that treatment you are taking it erratically, that can lead on to abnormal uterine bleeding. And then there is a category of drugs, medicines which are being given for certain conditions, but that is mandatory to be given for that condition. In that case, iatrogenic, which is induced by the drugs which you are consuming. So that is another cause of bleeding. And then there are certain reasons where none of these exist. You don't see any of these structural, you don't see any of these non-structural. Non-structural means these cannot be imaged. These conditions cannot be imaged, but they are based upon your history, the history that you give. They are also based upon your physical examination, and then by confirmation through your laboratory investigations. So that will confirm the non-structural causes of abnormal bleeding. And then there is a last category, which means not otherwise classified. When your picture doesn't fit into any of these structural or non-structural causes, then that is labeled as not otherwise classified. Few examples of not otherwise classified. Sometimes you get a report on ultrasound that the endometrium is showing AV malformations, arteriovenous malformations. Now, that is something which is not yet established or included into any of these classifications, but this will come under the heading of not otherwise classified. Or isthmocele is one condition. Isthmocele is mostly seen in women who have had a cesarean section, and because of that scar, sometimes a pouch like thing forms on the inside of the uterus. So when menstruation happens, blood gets trapped into that pouch, right? So after your menstruation is over, that blood, collected blood from the pouch, with your movements will keep on seeping through the cervix, and you will keep on having spotting, which is mostly not red in color, it is brownish in color, because this is an old collected blood. And but this will continue for some days after your regular menstruation is over. So isthmocele and AV malformation, so these are some of the conditions which now come into this category of not otherwise classified. Now, how do we finally diagnose any of these conditions? As I said, the structural conditions, like if there are any polyps, if there is adenomyosis, leiomyoma, or malignancy. Now, all these can be diagnosed by ultrasound, by your first of all, the most important thing is your history, the pattern of your menstrual cycle, and the examination done by the doctor, and finally the investigations ordered. And in the investigations, a transvaginal ultrasound, transabdominal ultrasound, MRI. So basically, these are the conditions. And if there is a malignancy, then sometimes the CT, contrast CT, is also done to evaluate any of these patients. But for non-structural, like if there is a coagulation disorder, how do we know whether it is a coagulation disorder? Much will depend upon history in such cases. So if anybody is having heavy menstruation right from the time she started with her menstruation, from the time of menarche, so any history, the history will be very important in these conditions. So heavy bleeding right from the day you had menarche, right from the time you started with your periods, you have been having heavy bleeding, and as a consequence of heavy bleeding, you are also suffering from anemia. Okay, and then you went for some surgical procedure, a minor procedure, and it took long time for the bleeding to stop. Or you went for a tooth extraction, and it took long time for the bleeding to stop. Or you have easy bruising, just an easy bruising, you hit some place and you have a bad bruise which you don't expect for that kind of trauma, a slight trauma. So easy bruising, that also. Or you have epistaxis, bleeding from the nose, very frequently happening. We have bleeding from the nose. So I and again, where family history is very important in such conditions, right? So family history, along with any of these features which are there, should raise the suspicion of you having a bleeding disorder. Now, what do we do? How do we confirm whether this bleeding disorder is there or not there? In that case, we go on for a spectrum of investigations. And in the bleeding disorders, there is one condition known as von Willebrand disease. Von Willebrand disease, this is a hereditary disease which is passed from the generations, your generation to generation. So this is the most common cause of heavy bleeding in youngsters, and in the type of history that I have just described. So you can go in for the investigation of von Willebrand factor. You can also test factor 8. You can test other factors also, but at the same time there are certain tests which evaluate your coagulation status: PTT, APTT, factors 8, von Willebrand factor. So all these, this is a routine investigation for anybody suspected to have. This is a panel of investigations which is done in cases who are suspected to have coagulation disorder. So if you have any history, or if you think you have any such signs and symptoms, do contact your doctor, and you can discuss your problem with your doctor. Now coming to how do we go about the other conditions. So if it is ovulatory dysfunction, then in that case, ovulatory dysfunction is there or not can be easily seen on ultrasound. Ultrasound documentation for ovulation, whether this is happening or not, that can be there. Otherwise also an endometrial biopsy, which is usually outdated these days, this can also tell you whether ovulation is happening or not. But endometrial biopsy, since this is a invasive procedure, so nobody prefers it these days. Simply documenting ovulation on ultrasound will tell you whether any ovulatory dysfunction is there, which is responsible for your abnormal menstrual bleeding. Now coming to the endometrial pathology. As I said, endometrium is hormone dependent. It can be, if hormones are sufficient, you will have normal periods. If there is dominance of some hormone, you will have excessive bleeding. If the hormones are less in amount, then you will have less periods. So that evaluation can be done by taking an endometrial sampling. Endometrial sampling, you need to go to the hospital after your your thorough history taking, physical examination, investigations. Endometrial biopsy is taken. This can be taken as an office procedure, or this may be taken into the operation theater. There are various procedures. A simple DNC can be done, a sampling can be done, taken with the Pipples cannula, which is the latest thing we do these days. Or if you have the doubt that there may be some other endometrial pathology also, like there can be endometrial polyps, or there can be if you doubt that there can be some malignancy, in that case it's better to do a hysteroscopy. In malignancy it's better to avoid, because this will lead to spillage into the peritoneal cavity. But endometrial, simple endometrial thickening, which is very common in hormonal problems, which is also common in PCOS patients, so taking a and polyps, so in that case hysteroscopy is the best thing. You through the hysteroscope you can directly visualize the endometrium and any polyps or any abnormal area, abnormal looking area. You can take biopsy from that, or you can take from different walls of the endometrium, different areas of the endometrium uterine wall. You can take a biopsy. So this is a see and diagnose type of a thing. So all this can be done. Sometimes there are places available where in one go everything can be done. That means you go, the doctor takes your history, she does examine you, then you are subjected to investigations, and when investigations indicate that there is a requirement of a biopsy, so in office setting you can do hysteroscopy, and then by evening you can go home. So endometrial pathology can be taken care of like that. In case of, as I said, all those structural anomalies, they can be taken care of by the imaging techniques and by the examination and management. Finally, what is the management for abnormal uterine bleeding? The management will much depend upon the condition which is responsible for abnormal uterine bleeding. So if you have polyps, it can be easily taken care of by doing hysteroscopy and hysteroscopically removing the polyps. So polypectomy is the procedure of choice for endometrial polyps, and once you have taken out these polyps, this can be subjected to histopathological examination, and histopathological examination, whatever the report comes, accordingly you can you can be treated based on that report. Now, as I said, most of the times these polyps are formed under hormone effect. If there is excess of estrogen, it might result in this thing, endometrial polyps. So the treatment can be a simple hormonal treatment, correcting that hormonal imbalance. So simply medical treatment can cure these polyps. For adenomyosis, much will depend upon your symptoms. How severe symptoms do you have? What is your age group? And whether you have completed your family or not. So accordingly this can be treated medically also. And if you are already near your perimenopausal age group and you have very bad symptoms, you have excessive bleeding and you have very bad dysmenorrhea, which is a hallmark of adenomyosis. It also differentiates it from fibroids. The dysmenorrhea or the pain during menstruation, that will not be so severe as it happens in cases of adenomyosis. So if you are already completed your family, you are nearing menopause in your late 40s and you have severe symptoms, in that case you can go in for a hysterectomy procedure. That means the removal of the uterus. But if you have a focal adenomyosis, you are young, not completed your family, you don't want to sacrifice your uterus, not even a doctor would want to sacrifice your uterus. In that case, if it is a focal, of course, if it is a diffuse kind of adenomyosis that cannot be cured, that cannot be dissected away, but a single focus of adenomyosis that can be taken care of, that can be removed surgically also, and thereafter you can start with the hormonal treatment. Or even these days, the hormone releasing copper T devices are available, which we call it Mirena. So Mirena is, if it is inserted inside the uterine cavity, this will slowly keep on releasing hormones inside the uterine cavity. Now that is the advantage, is you don't have to take that medicine orally, because all these medicines will have some systemic effect as well. But when it is given at the point where it is actually required, that means inside the uterus, it has to ultimately act on the endometrium of the uterus. So if it is released there, you will not have any systemic side effects of the hormone, and you can be very comfortable with Mirena insertion. Otherwise, also for any endometrial pathology, like if there is endometrial hyperplasia, there is abnormal bleeding which is because of a thickening of the endometrial lining or hormonal imbalance which requires the progesterones to be given, whatever may be the age group, in that case the first choice should be the medical treatment, either hormone to be given orally, or it can be given through this hormone releasing intrauterine device, which is Mirena. I think people have very hesitant. People are usually very hesitant to have that device inside the uterus, thinking it's a copper T or something like that. It's not releasing copper T. So remember, copper T releases copper, but Mirena releases hormone progesterone. So otherwise, you will have to take it cyclically every time, for maybe for 21 days or for 10 days or for a week, for during every cycle, and you will have your systemic side effects. So it's always better that the first line of treatment may be a medical treatment. If medical treatment does not help abnormal uterine bleeding, then only surgical treatment is the last treatment line of treatment. In these days of advancements, I don't think that for hormonal treatments or for management of abnormal bleeding, right, any kind of straight away any kind of landing up in hysterectomy is the choice, unless these are structural abnormalities and you are debilitated by the symptoms and your hormonal treatment or a medical treatment is not helping. If malignancy is suspected, in that case, obviously then the treatment will be entirely on a different platform. It will be a different kind of a surgery, not a routine hysterectomy, but the hysterectomy has to be a little advanced, along with removal of the lymph nodes. That will depend upon the stage at which the patient comes. And if it is a pre-malignant lesion, pre-malignant means it's not yet turned into a frank malignancy, but there are certain features which indicate that maybe a year or 10 years later or 5 years later this can turn into a malignant condition. In that case, again, it will be better you, if you are young aged, of course Mirena can help, oral progesterones can help. And if you are nearing your perimenopausal age group, so you have your family completed and you don't want to retain you're too scared, in that case, for pre-malignant lesions, again hysterectomy can be done for any kind of abnormal uterine bleeding. Now I may tell that when we are talking about malignancy, there is a certain category of patients which are genetically predisposed to have uterine cancer. Okay, we call it Lynch syndrome. Lynch syndrome means if there is a genetic predisposition, means there is a family history of uterine carcinoma, ovarian cancer, breast cancer, colorectal cancer, or cancer of the GI tract. So this constitutes a Lynch syndrome, and this can be diagnosed by doing your genetic testing, even in patients of PCOS. So these are the kind of patients who are more prone to have uterine malignancy. Now, if it is known that you have this strong familial tendency for uterine malignancy, in that case it's very necessary that you be in regular touch with your doctor, and you go in for screening every time, she as per the norms as she advises. As long as your endometrial lining is normal, as long as you are getting normal periods, it's okay. But if it is you have completed your family, you are 40 years old, and you have a strong family history, or this thing genetically linked history of cancers in your family, in that case it's better to get your uterus removed rather than waiting for some mishap to happen. So these are few, very very few, and these are very rare conditions. I tell you, I just told you for the sake of information. If any one of you has this kind of a history in the female in the family, not to scare anyone, or not that everyone should start thinking, oh maybe I'm having malignancy. No, it's a very typical set of people who will have it, and it's very very rare. So, in short, what I should say, that if you have any kind of abnormal uterine bleeding, many times what happens during perimenopausal age group, most of the women think it's part of a normal menopausal transition. You keep on having bleeding for many days, and you have heavy bleeding, and then you stop bleeding for 2 to 3 months, and then again suddenly one day you will have very heavy bleeding, and it's part of normal transition, and we don't need to go to the doctor. Don't ever think like that. Whenever there is, even for if it is a normal transition, your doctor will be able to know that this is normal transition. But even in that condition, because this happens because of the hormonal imbalance that needs to be corrected, a normal menopause is one where periods gradually, the duration of the menstrual cycle keeps on increasing, and the amount of bleeding also keeps on decreasing. It's not that after 2 3 months you will have a heavy bout of bleeding. That's not normal menopause. Normal menopause will be if you have start have the duration of cycle keeps on increasing gradually, and the amount of bleeding also keeps on decreasing gradually. But if you have any deviation from this normal, it's mandatory that you consult your doctor, you get this hormonal imbalance corrected, and then you'll end up with your normal menopause. It's not necessary at all unless not modified by the medical treatment to go in for a surgical management. So that is all about abnormal uterine bleeding. I hope you have understood the reasons for abnormal bleeding. You have understood that you need to consult your doctor. What are the conditions which can lead to an abnormal uterine bleeding? What exactly is abnormal? What is normal for you? And what is abnormal for you? And if you think at any point of time in your reproductive life, that means starting from menarche, the day you start your menstruation till the end, and the day you land up into menopause, anytime, any point of time, you do need to consult your doctor. The treatment is very very easy. It's just a correction of your hormonal milieu interior, that's it, which is required. So thank you so much for listening to me. If anyone has any queries, you can always contact us, or you can just ask me if you have any queries. So even if you are listening, you'll get to listen to this lecture later on, and you find you fit into some of these conditions, you can always contact us. Thank you. Hello. हाँ जी राकेश जी, हो गया मेरा कंप्लीट, बट वो पीछे रिस्पॉन्ड नहीं कर रहे।
क्या नाम, सॉरी?
लेक्चर कंप्लीट हो गया है, बट वो पिछों दी वो कर नहीं रहे रिस्पॉन्ड।
मैं अभी बोलता हूँ उसको।
हाँ उनको बोलो कि उसको बंद कर दे। इफ समबडी हैज सम क्वेश्चंस तो वो मुझसे पूछ लें क्वेश्चंस।
ठीक है मैम, मैं बोलता हूँ।
और आप आ जाइए इधर।
हाँ हाँ, एक मिनट, मैं बाद में उसको मेरे वन को बोल दे देता हूँ, वो करता है ना।